science of medicine. Today I want to talk about the role of testing in the making of diagnoses clinically. This is an important topic, and I've discussed elements of this in previous talks. So the first thing I want to do is sort of lay some groundwork about ways that we, from a medical standpoint, know or construct arguments. These are based on science, which is a human endeavor that seeks to understand how the universe works. It's a construct. There is various scientists and clinicians that work to put forward falsifiable hypotheses and theories. They test these predictions, and then they look at the evidence to either support or refute these. There is a value to that evidence that is weighted based upon whether it is direct, which is better than indirect measure. Larger, more reproducible studies with controls are better than smaller ones. Sometimes people use religion, which is a human endeavor that seeks to explain why the universe is the way it is and our place in it, as a pseudo argument. And what I mean by that is, in a religious argument, you're again explaining why instead of how. It has non-falsifiable beliefs. It values that belief or that faith, and it was revealed to humans. And sometimes people will make what I will term a pseudo-religious argument in a scientific realm. And that is to use these religious tenets, that is non-falsifiable beliefs in particular, that does not adhere to evidence or value these things. And so when I talk about medicine, I'm going to talk about it from a scientific standpoint, and that's important for what follows. So the first thing that I mentioned is this idea of falsifiability, and this has its relationship with the mathematical statistical significance in the following way. So if a hypothesis and a theory has to be falsifiable, I can never demonstrate that it is correct. This is an important concept. I can't prove that a hypothesis is true. I cannot prove that a theory is true, because truth is something outside the realm of science. So I can actually formulate a null hypothesis, the opposite of what I'm trying to demonstrate. And I can show this, though, to be false and estimate the error associated with doing so. So it's a backwards way. I cannot prove a hypothesis, but I can disprove a null hypothesis. That still allows for the falsifiability of the hypothesis. And over time, these hypotheses become formulated into theories, and we can construct different ways of explaining things, such as a theory of gravity, which stands the test of time. But it doesn't mean that we could not have somebody who could come up with a null hypothesis that would disprove this. So statistical significance is a mathematical evaluation as to whether or not some set of observations or measurements reflect a pattern, for example, a hypothesis, or reflect random chance, which is what we would formulate the null hypothesis as. And typically we frame this significance in terms of the difference between a control and experimental groups, but because we can never be 100% assured between a relationship between two or more variables, that is, it's got to be falsifiable, we estimate the error associated with there not being a relationship between those variables. That's how we get around this falsifiability. So, what kinds of considerations do you have in a patient encounter? First, I try not to do any harm. We try to actually never hurt a patient, certainly never intentionally. Second, we don't want to miss a serious disorder, even if it is less likely. Now, I'm not talking about missing something that might have an incidence of 1 in a billion or something, ridiculously small. But things that, might be less common, but if you don't diagnose the person with that and treat it appropriately, they may die or they may have serious consequences. The next thing is this a diagnostic problem? Do I have to figure out what's wrong with the person? Or do I have to consider a management decision? That is, a patient has a known diagnosis, or at least a presumed diagnosis, I should say. And is that presumption being supported continuously? Does it have to do with, is this person's diabetes better controlled than it was last month or last 3 months? And I'm going to talk today about diagnostic problems. So for a diagnostic problem, we use Bayes' theorem. We play the odds. So Bayes' theorem allows a person to calculate an updated probability of some event given additional positive or negative information. For example, if a person comes in and says, Dr. Penley, I have a cough. In the outpatient ambulatory setting, the most common causes of cough are postnasal drip, asthma, something related to infection, or acid reflux. But if a person located in New York City in, let's say, April of 2020, where the SARS-CoV-2 pandemic was rampant, and they came in with a cough and fever, and they couldn't smell, anosmia, and they also had hypoxemia, low blood oxygen level, then the chance that this is an infection with SARS-CoV-2 is much higher than postnasal drip, asthma, or acid reflux. But again, we can never know the right answer, but we can understand when additional information can be useful in making a decision, and how to interpret this result in light of this additional information. And this is what I want to talk about today. So, when is testing useful? A diagnostic test is useful when there's a question as to diagnosis, and the result of that test will significantly increase or decrease the probability of the diagnosis. And what that means is that if I have a high probability that the person is infected with SARS-CoV-2, doing a test may not be very helpful to me. So what's the probability that a patient's cough, fever, anosmia, hypoxemia is due to respiratory infection with SARS-CoV-2? That's a diagnostic question. And I look at the pre-test probability of that diagnosis. So if that pre-test probability of a diagnosis is very high, then if I do a test, it may not change that appreciably. And so if that's the case, I don't do the test. I refrain from doing it. I don't want to spend the money, don't want to do the time. I might get a false result. If on the other hand, it will significantly change the probability of that diagnosis, then I want to actually do that test. And that's where the decision-making process is. So a little bit of backpedaling here. First off, in terms of diagnostic medicine, I want to specifically address disease versus illness. So a disease is a disorder in which there's a change in the body's normal structure and function. It has a cause, and there is a diversity of normal within the population. For example, fasting blood glucose is between 70 and 100 milligrams per deciliter. And so I have to understand what normal is before I can understand what abnormal is. But illness is a distress. It's subjective, felt by the patient due to the pathogen's effect on the body or the body's response to it. In fact, many of the things that you and I feel when we're ill is actually our body's immune system releasing various cytokines, various chemicals that cause us to have fever, that cause us to feel achy, and not the pathogen itself. Now, within diseases, I would differentiate those that are intrinsic, inborn, genetic, for example. Cystic fibrosis, a very common genetic disorder in the Caucasian population. There is a loss of function that leads to this disease. There's a specific deletion, amino acid 508, phenylalanine on chromosome 7, that leads to a defective folding of a particular ion channel. That means that I develop thick mucus in my lungs, I get respiratory infections, I also have problems with the pancreatic duct digestive enzymes, and I have problems therefore with digestion. This is in contrast to acquired diseases. For example, humans are afflicted with many pathogen-based diseases. Mycobacterium tuberculosis worldwide causes tuberculosis, which has a very high disease burden worldwide. Our body can attack itself and lead to autoimmune diseases, type 1 diabetes, mellitus, rheumatoid arthritis. Sometimes we don't get proper nutrients, and that can lead to a nutritional disease, such as iron deficiency anemia. There are certain chemicals that we can ingest or have on our skin or put in our system, breathe in, that can lead to damage. For example, ethanol leads to liver damage. And then there can be physical things, either in the way of UV radiation, for example, leading to cancer. Now, I can have diagnostic tests, those types of tests that help me in making a diagnosis, that can either be direct, that is directly related to a particular underlying cause of the disease, or indirect. A direct is directly related to the cause of the disease. For example, if I thought that a person had cystic fibrosis, I could do the specific genetic testing to allow for mutations that cause cystic fibrosis. If I suspected that there might be a particular bacterial infection, I could obtain a sample, streak it on a culture plate, and do a gram stain that would allow the culture to grow, and then I could look for the cultured bacteria. I could identify them with things like matrix-assisted laser deionization, time of flight mass spectrometry, or other methods that I could use. Indirect tests are not as helpful in that it looks at an indirect result. For example, the body's response to something. For example, if I have an inflammatory response, I will have C-reactive protein that I can measure in my blood that is elevated. But it doesn't necessarily mean that it's an infection. It could be, could not be. I could look for particular evidence of liver damage because I get hepatic cells, hepatocytes, that rupture and increase alanine transferase, aminotransferase, or LAALT. But this is not saying specifically, because there are other cells that also have ALT. Or some people have had a pre-purified protein test where a small amount of this pre-purified protein will be injected subcutaneously, and then you will look for a type 4 hypersensitivity reaction, sort of swelling up around that, as an indication that you've been exposed to tuberculosis. So indirect, less reliable than direct. So how do I assess the diagnostic value of a test? Well, we have what's called medical sensitivity and medical specificity, and positive and negative predictive values. And what you can think about is that these test results will be in a rubric of two possibilities. I either have the disease or I don't have the disease. I either have a positive test result or I have a negative test result. And there are some things in terms of what's a cutoff for a positive or a negative, and that those are valid and important considerations that are taken into the determination of the medical sensitivity and specificity. I won't talk about these here today. But if you can think about that 2x2 sort of table, the true positive is where I do have the disease and the test result is positive. And I assess that through the sensitivity. A true negative result, when I don't have the disease, is addressed through the specificity. But unfortunately, I also have false positives and false negatives, and those influence both my positive and my negative predictive value. So let's look at this a little bit more detailed. A high sensitive test means that it detects the test well. That means that for the people with disease, they will have a positive test for the most part, which means that there'll be a relatively low number of false negatives. So if I have a high sensitivity test, I'm likely, if I have a negative result, the disease is much less likely. On the other hand, at high specificity detects those people who don't have the disease. That means I'm going to have a very low number of false positives. So a highly specific test yielding a positive result makes that disease more likely. And these are important but subtle characteristics that are important for being able to assess positives and negative test results. So the easiest way to actually do this is to work through examples, but I want to give you some caveats. The first is that medical sensitivity and specificity are related to not only the characteristics of the test, that is, whether that test is very specific and sensitive for a particular disease, but also the pre-test probability of the patient having the diagnosis. And I'll talk about that in detail. The pre-test probability can be based upon certain validated clinical rules or from measures of prevalence, particularly for infectious diseases. But one of the assumptions in the calculations that I'm going to show you are that the prevalence of that disease is stable. For example, ischemic heart disease in a given year. But in the case of pandemics or rapidly changing infection rates, such as SARS-CoV-2 during our pandemic, this is not a reliable estimate. And so you have to look at whether the prevalence is increasing or decreasing to know whether this is a lower or an upper limit. So let's talk about an application. I've chosen a particular commercially available influenza test, QuickView. It tests for both influenza A and B. It has a medical sensitivity of 73% and a medical specificity of 96%. So let's say that the prevalence of influenza in the particular area that I live in September is low, 0.5%. And you perform a test on the patient with flu-like symptoms, and the flu test is positive. What does this mean? How do you interpret this? So I'm going to consider that I have 10,000 people, and in September, if the prevalence of flu is low, 0.5%, that'll mean that I'll have 50 people that'll have flu and 9,950 people who don't have flu. If I apply, if I apply the particular test that I have in question with a medical sensitivity of 73%, that means that 73% of those 50 people, or 36, will have a positive flu test, and 14 will have a negative flu test. And of those people without influenza, 9552, or 96% of the 9950, will give an appropriately negative response on that test. But 398 of them will test positive. It'll be a false positive. And that means that my positive predictive value for this test is actually pretty low, about 8%. Because if I get a positive result, it is overwhelmingly a false positive in terms of the likelihood. So how do I interpret my test? So if I had done no test, the patient would have a 0.5% chance of having influenza. And if I perform the test and it's positive, they have an 8% chance of having flu with this. But that means that if I did the test result, I have a 92% chance that the person doesn't have flu. So this is not a valuable additional test to do during this time, because the person unlikely will have influenza. And so it doesn't help with this diagnostic question. And if I get a false positive result, it can lead to potential harm, because I might give them therapy for influenza, which is ineffective, and I might miss a more likely diagnosis that might be treatable, let's say a bacterial pneumonia. So it's very important that you understand this. In low prevalent times, doing a test like this is not going to help you. But let's say you say, well, what about in January when the prevalence of flu is high? Then you perform a test on a patient that has flu-like symptoms, and the test is positive. How do you interpret this? Well, now I can go back to my 10,000 people. In January, 4,000 of them with flu-like illness symptoms would have flu, and 6,000 won't. So now if I apply my test, now my positive predictive value is much, much higher, 92%, because the majority of the positive results are going to be those with influenza as opposed to those without. So in this case, I started with a 40% chance of the person having influenza, almost a coin toss. If I had said, well, they have flu-like illness, do they have flu or they don't have flu? I could flip a coin and get about the same odds, a little bit poorer odds, whether I call it heads or tails. But now I do this test result, and now with that positive result, I go from 40% to 92%. This is a very valuable test then in this scenario, and it is an appropriate test to do in this case to see if the person has influenza. So what are my take-home points on this? So take-home point number one is a diagnostic test is useful if there's a question as to the diagnosis, and the test result will significantly change the probability of me making that diagnosis. That's number one. Number two, the estimates of the probability of the diagnosis involve two things. The first is the pretest probability of the diagnosis. If that pretest probability is exceedingly low, then the test is not likely going to help you. If the characteristics of the test, which also are important in this, are such that they're very poor, if you had a medical sensitivity or specificity that were really, really low, then that's another reason that you wouldn't likely use that test. And generally, those tests are not available commercially because they can't sell. And then remember always that the take-home point of direct test having greater weight than indirect test. Direct evidence is a much better use, a much better weight than indirect evidence. So I hope that this has helped you learn a little something about diagnostic testing. As always, if you enjoy these videos, be sure to subscribe so that you can learn when I post new videos. And I will see you next time on Science and Medicine. Thank you very much.